Good morning, everyone, and thank you for joining us for this week's virtual lecture. My name is JP Britton, endocrinologist at Mayo Clinic and co-host of these lectures. This morning, I have the honor and the pleasure to introduce esteemed colleague, Dr. Brooke Nickel. Dr. Nickel is a National Health and Medical Research Council Emerging Leader Research Fellow at the University of Sydney School of Public Health. Her research focuses on understanding the psychological impact of cancer diagnosis and treatment and how to improve cancer communication and decision-making. Her research also examined how different labels for low-risk thyroid cancer impacts treatment decision-making and patients' outcomes, including quality of life. And this research has been published in high-impact journals in the field, including Thyroid, JAMA Head and Neck, and the BMJ. This work has reopened the discussion and debates about the labeling and the impact of low-risk cancer diagnosis internationally. Thank you, Dr. Nickel, for your time. I know you are joining us from Australia. It's very late there, so we really appreciate you having the time to talk to us about your research. Thank you.
No worries. Thanks, JP. And hi, everyone. Thanks so much for inviting me to give this talk. I hope it's something that's a bit thought-provoking for everyone and different. And I welcome your questions and your comments at the end. So I guess I'll just jump right into it. And JP or anyone else, if you have anything you want to add or anything along the way, just feel free to jump in and cut me off. So as JP said, my name is Dr. Brooke Nickel, and I work at the Sydney School of Public Health here in beautiful, but actually today quite chilly, Sydney, Australia. I'm a postdoctoral research fellow with the NHMRC, which is the National Health and Medical Research Foundation. And as JP said, my work has focused on the psychosocial impact of cancer diagnoses and treatment. And my PhD was focused on low-risk thyroid cancer. So before I start tonight, I will just say that, yes, it is quite late here. It's about 10 p.m. And I'm also 5 months into my maternity leave here. So I have a toddler sleeping in the room next to me and a 5-month-old as well. So if, I go off track a little bit, I do apologize for that, but otherwise I have no other excuse. So my talk is called, Can Less Really Be More? The Impact of Thyroid Cancer Terminology on Treatment Choice. So before I start, I just wanted to say that I have no conflicts of interest to disclose. Now I'm just going to start my talk tonight by telling you a story about a patient I interviewed a few years ago, and his name was Ian, and Ian is 72 years old. So Ian felt like he had a pinched nerve in his arm. He went to see his GP and he got sent for an ultrasound. He was told there was nothing wrong with his arm, but that they found a nodule in his neck. He had another ultrasound of his neck and then a biopsy. Ian was diagnosed with papillary thyroid cancer less than 1 centimeter in size. He recalls thinking that I couldn't sleep for probably 2 weeks after that diagnosis. He had a thyroidectomy and now requires lifelong thyroxine. He says, I wake up in the middle of the night to take my tablet, and I've been doing this for about 1 year now, over 1 year. And he has had ongoing voice issues. Ian said, I'm worried all the time, sometimes even today, 1 year after. Even today, sometimes I go to bed and sort of think of, okay, what's wrong with my voice? And am I going to get cancer again? Or did it spread, I've got that worry in my mind all the time. There's no doubt. He says, well, they say it's cancer. I tell you what I'm thinking. I'm going to die. Whatever they tell me, I'm going to die. I'm going to die soon. So Ian's story represents just one thyroid cancer patient's story, but it does show that there is a wide-ranging impact of diagnosis and treatment of thyroid cancer. And I just want you to keep Ian's story in the back of your mind as I go through my presentation. So there's an impact of being diagnosed on your psychological well-being, your physical well-being, and your quality of life. Now, in terms of your psychological well-being, this can display things such as distress, shock, anger, fear, anxiety, depression, uncertainty, but it can also a diagnosis can also bring relief, comfort, and confidence. In terms of physical well-being, this can impact things like treatment side effects, such as a scar on your neck, problems with your voice, calcium imbalance, and fatigue. And overall quality of life are things such as reliance on lifelong thyroid hormone replacement medication, the change in life that you have to do with that, your relationships with family and friends, and also financial and insurance difficulties. Now, there is a growing acceptance that the increase in thyroid cancer incidence is in part a result of overdiagnosis of small papillary thyroid cancers of indolent clinical course. Active surveillance has now been suggested and trialed as a safe and effective way of managing these cancers in order to avoid possible overtreatment. Now, overdiagnosis is a diagnosis that would not cause harm if left undetected and untreated. And it is not possible to detect on a case-by-case basis. So you can't look at a patient in your clinic and tell them with confidence whether they've been overdiagnosed or not. So at present, epidemiological analysis can identify population-level trends suggestive of overdiagnosis. And this is largely as a result of a dramatic increase in diagnoses with no change in mortality across the population. So as I said, it's not possible to detect on a case-by-case basis. And so it has been estimated that 470,000 women and 90,000 men have been overdiagnosed with thyroid cancer in the past 2 decades across 12 countries. And this estimate comes from a paper published in the New England Medical Journal in 2016. And more recent estimates have suggested that over 830,000 women and 220,000, that's to say men, have been overdiagnosed between 2008 and 2012 across 26 different countries. And that's a more recent estimate by some of the same authors. And here in Australia, a study published last year estimated that 73% of thyroid cancers were overdiagnosed between 1982 and 2012. And now the poster child for thyroid cancer overdiagnosis is South Korea. And many of you might have seen this graph before, but as you can see, the incidence of thyroid cancer is increased dramatically over the past 30 years. And this incidence has largely been driven by the incidence of papillary thyroid cancer. And in 1999, this incidence started to go up quite dramatically. And what happened in this year was that South Korea introduced a population-level thyroid screening program that coincided with their other cancer screening programs. So they started screening many, many people across their population. And this really just drove up the incidence. But as you can see, thyroid cancer mortality stays the same. So this large change here is really suggestive of overdiagnosis, where the incidence is driven up dramatically, but the mortality stays the same. So really what we're doing is just diagnosing a whole bunch more people, but there's no change in long-term outcomes for these patients. So my work really looks at what the impact of diagnosis and treatment of low-risk papillary thyroid cancer has on quality of life and health behavior. And how does the terminology used to describe a diagnosis of papillary thyroid cancer influence psychological outcomes, treatment choices, and benefit-harm trade-offs? So I'm going to start by telling you about 3 studies we conducted to understand the impact of diagnosis and treatment of papillary thyroid cancer. The first one was with clinicians, the second one is with patients, and the third one is with patients, a content analysis across a number of patients that had been diagnosed. So this first one was published in 2017 in Thyroid. And the aim of it was to understand how clinicians perceive a diagnosis of papillary microcarcinoma, so papillary thyroid cancers less than 1 centimeter in size, potential changes to terminology, and treatment options available to patients. And so the method we'd use were semi-structured interviews with 22 clinicians in Australia. And these were surgeons and endocrinologists who treated patients with thyroid cancer. And they were recruited through professional organizations, specialist hospital clinics, and the snowballing technique. And we used a thematic analysis to analyze this data. Now, as you can see here, the majority of participants were surgeons, majority were female. There was a range in experience, and most came from urban centers. And so what we found was that clinicians generally didn't discuss the impact of quality of life or downstream consequences with their patients. Some discussed the prospect of overdiagnosis and overtreatment, with them saying, but for most patients, if they know they've got cancer of the thyroid, want something done about it, then I'm happy to do that for them. But I realize that we're probably overtreating them. Often a belief of what the patients would want and benefit from was discussed. I'd predict 10 out of 10 times you tell people they have cancer in their neck, and then they'll say, well, when is it coming out? And another surgeon said, I will still probably remove it because I think in the current climate, most people would want it removed. Many clinicians discuss the idea of surgery carrying little to no harm for the patients, with one surgeon saying, we just give them the option as to whether they would just have a hemithyroidectomy or a total thyroidectomy, because the prognosis would be unchanged with either approach. And another surgeon saying, I have concerns about whether tumors do undergo transformation to a high-grade tumors over time. And I don't know if that's the case that we select them out so well. So I'm concerned about patients with life expectancy of greater than 10 years of the suggestion of monitoring, because what's relatively a simple treatment can turn into a life-threatening situation. And now with the study with patients, this study was published in 2018 in BMC Cancer, and the aim of it was to develop an in-depth understanding of patients' experience of diagnosis, their treatment preferences, and their decision-making. And the method we used again were semi-structured interviews with 25 patients diagnosed preoperatively with papillary microcarcinomas less than 1 year since diagnosis and treatment. They were recruited through clinical collaborators and an endocrine surgical database. And again, we used thematic analysis to analyze the data. Now, the majority of these patients were between 50 to 75 years of age. Again, the majority were female. They were well educated, and the majority they had their thyroid cancer discovered through an imaging finding. So what we found with these patients was that the diagnosis pathway did vary widely. And there was little mention of clinicians discussing any downstream consequences for the patient. With one patient saying, the thyroid surgeon said to me, this is a good result because it's so small and it's encapsulated, and we found it early and everything. And I said, so what are the ramifications for me? And he said, basically, once you remove it, that should be end of story. Patients discuss feeling uninformed about their diagnosis and treatment options, with one patient saying, I would have also liked someone to be frank about, the controversy, that there's a way of following it up by monitoring. We found that many patients reported physical and psychological effects associated with their diagnosis and treatment. One patient saying, the thing is, my voice is not the same. It's not the same. And another patient saying, I know they did nick one of the parathyroids, and since I've had my thyroid out, I've been having a lot of trouble with my calcium levels, trying to stabilize my calcium levels. I've been in and out of hospital having my calcium infusions. Another patient saying, I've had so many times that I've felt so tired. I felt pretty awful a lot of the time since the surgery. And another one saying, I'm worried all the time. Now, the last study here I'm going to talk about is a content analysis of health-related quality of life. And we published this in JAMA Auto in 2019. And the aim of this study was to better understand the range of health-related quality of life outcomes associated with diagnosis and treatment of differentiated thyroid cancer, and whether these outcomes varied by type of surgery. So to do this, we used a content analysis method and we had over 1,000 patients responses to open-ended questions about outcomes and concerns. So this was part of a larger study where they answered a number of questions, and a few of those questions were open-ended and just asked the patients about any additional outcomes they wanted to discuss or any of the concerns. And a content analysis is basically a quantitative analysis to explore to explore qualitative questions and then group them into categories. And additionally, we did a quantitative analysis to explore whether surgery type was associated with health-related quality of life issues or any adverse effects of treatment. And patients were aged 18 to 79 in this large cohort, and they were recruited through a post-surgical thyroid cancer center and a population-based cancer registry. And so what we found here is that 89% of these patients had papillary thyroid cancer, 56% had tumors smaller than 2 centimeters in size, and 79% of them received a total thyroidectomy. And overall, 77% of the patients reported health-related quality of life issues or concerns following a diagnosis and treatment. So as you can see here, 66% of them reported physical effects, 19% psychological, 8% lifestyle, and 23% had no or very minor effects or issues. And for the first three, the physical, psychological, and lifestyle, patients could be grouped in any of them. So it didn't have to be one standalone one they were feeling. This was overall. So in the physical category, the main effect or sub-theme that we found was fatigue, and this was present in 33% of these participants, with some patients saying constantly fatigued and struggling with daily activities. In the psychological category, the top theme or sub-theme was emotional distress, with 13% of participants having this. And an example of this is one patient saying, upset to have a cancer diagnosis and worried about the possible link to other cancers. And lastly, in the lifestyle category, impact on work was present in 4.8% of patients in this category. With some, and this is just an example of one patient saying emotional ups and downs, so has had to give up work. So lastly, we found that the odds of reporting these quality of life issues or an adverse effect, so in any of those three categories, the physical, psychological, or lifestyle, were 1.5 times higher in those who had a total thyroidectomy compared to patients who underwent hemithyroidectomy. So just going to quickly summarize these first three studies I talked about. So basically what we found in these studies was that clinicians may underestimate the impact of surgery on patients' quality of life and side effects. Patients often feel uninformed about options and potential consequences of treatment. Patients also report wide-ranging quality of life issues across the psychological, physical, and lifestyle domains, which are related to their diagnosis and treatment of these low-risk thyroid cancers. And lastly, what I've just touched on is that less invasive management may offer fewer adverse effects of treatment and better quality of life. So next, I'm just going to talk about three studies to understand the impact of terminology has on low-risk thyroid cancer. And so the first one was a systematic review, the second one was a randomized crossover trial, and the third is a discrete choice experiment. So I'll go through these one by one now. And just the concept of this whole body of work and these studies that I'm going to talk about next is that when you hear the word cancer, one often gets anxious. They feel worried, they feel scared, they have high levels of anxiety. And that anxiety can then lead to wanting surgery or wanting something done or wanting something more invasive quickly and intensely done. And you know, this may not be a bad thing, or it may, but what we wanted to understand is really how does that word drive these emotions and drive these decisions and drive these choices. And this whole kind of concept that came around from these early papers that were done, you know, about 10 years ago or so, which talked about changing the terminology for low-risk cancers. So not just low-risk thyroid cancers, but other low-risk cancers such as ductal carcinoma in situ and low-risk prostate cancer. And so changing this terminology has been recommended by the NIH and the NCI to prevent unnecessary diagnosis and overtreatment. And in these papers, like I just mentioned, it was proposed for not only low-risk papillary thyroid cancer, but also low risk prostate cancers and DCIS, which have low malignant potential. And there's also been some discussion by the WHO in recent years, and this is just a quote from their website here, which says there is an urgent need to integrate new understandings of cancer into cancer classifications internationally. So they do acknowledge that, you know, the term cancer can be wide-ranging, and we might need to now integrate this new understanding that we have to better discuss this with patients. And Otis Brawley, who was the chief medical officer of the American Cancer Society from 2007 to 2018, has also stated a number of times that we need a 21st century definition of cancer instead of a 19th century definition of cancer, which is the one that we've been using. And some of you might be familiar with this paper that came about, I believe it was in 2016, where they reclassified non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So they reclassified that term to take the word cancer out and try and get not only patients but clinicians looking at this differently. Now, this is, I know, a different type of cancer that, you know, is only identified after you've removed the thyroid, but it is an example of that, you know, that this can be done, that changing the terms can be done and has been done in order to kind of reduce the unnecessary overdiagnosis and ongoing treatment that may incur for these patients. So my work started in this area by conducting a systematic review on how different terminology for the same conditions influences management preferences. So we looked at this across a number of different studies for a number of different conditions. And what we basically found here was that more medicalized terminology resulted in a greater preference or more interest in more invasive managements. And then we conducted a study which looked at the effect of change of the papillary thyroid cancer terminology on anxiety and treatment preferences specifically. And we did this using a randomized crossover trial. So what we did is we gave participants a description of papillary thyroid cancer and a scenario which randomized the term cancer, lesion, or abnormal cells. So the scenarios were all identical other than these terms. And then they got the identical table of treatment options and outcomes to look at. And what we found was that over 72% of participants initially chose active surveillance as their main treatment option when they're presented together, along with allowing the individuals to directly compare the treatment aspects that are important to them. So overall, 72% of people chose active surveillance when they were able to look at all the different treatment options and you know, the benefits and harms of each treatment and compare them individually. And then we also found that a higher proportion of participants opted for total or partial thyroidectomy when the papillary thyroid cancer terminology was used to describe the condition. So when they heard that term cancer, more people opted for the more invasive management options. And lastly, we wanted to know what was really driving these treatment preferences. And so we conducted a discrete choice experiment. Now, a discrete choice experiment, for those who might not be familiar with it, is basically where you compare a whole bunch of different options and then you're able to see what is driving those options, what attribute is really driving the options of participants. And it's a method that has kind of come up through health economics and now is moving into more mainstream public health and other research. But it allows kind of you to tease apart exactly where the change is and what's driving that change. And so what we found here, sorry, I'll let you have a look at that first, but what we found here, and when we looked at the benefit-harm trade-offs, was that there was a greater willingness to tolerate side effects in the cancer condition compared to the lesion condition. So willingness to accept extra people needing lifelong medication was 3 times higher, willingness to accept people having calcium problems was 2 times higher, and willingness to accept fatigue was 2 times higher. So when people heard the term cancer, they were more likely to say, basically, it's okay to have all these things because it's cancer, versus if you were to tell them it was a lesion or abnormal cells. And so here, when comparing the cancer term to the lesion terms, we found that participants with lower health literacy compared to higher health literacy had a greater preference for more aggressive treatment options, regardless of the terminology used to describe the condition. So regardless of what we told them here, people with lower health literacy wanted more aggressive treatment options. So perhaps here they weren't able to really compare the benefits and harms of each treatment like people with a higher health literacy may have been able to. But we did find this finding really interesting. So just to really quickly summarize these terminology studies, was that patients prefer more invasive treatments when more medicalized language is used. And this study was really, that we conducted, was really the first time to show this. So that it was the first time to show that, you know, if you say the word cancer versus something like lesion or abnormal cells, that people have greater preferences for these more invasive treatments. And specifically, when the cancer term is used compared to a non-cancer term, there's significantly greater preference for surgery compared to active surveillance. Significantly higher levels of anxiety were reported. And there's a willingness to accept more side effects and the harms from treatments. So just kind of summing that up is that this body of work here does show that, you know, the language we use does matter. It does affect patients' outcomes and in terms of being psychological and in terms of what choices they're making and how they view their condition. And so all of this work then led myself and some of my co-authors to write this analysis piece in the BMJ to consider whether renaming low-risk conditions, including low-risk papillary thyroid cancer, if you know, renaming those, if it may help reduce overdiagnosis and overtreatment. And so we talked about, like I said, low-risk papillary thyroid cancer here, and we also talked about other things like low-risk DCIS and low-grade prostate cancer. And this was just really summarizing all the evidence that had been conducted and you know, really what the next steps were and how challenging doing something like this would be. And it was also very controversial. We got a lot of media on it. Some people took it the right way, some people took it the wrong way, but you know, it is an article that we wanted to be thought-provoking, but you know, we weren't trying to say necessarily what's the right thing here to do. We're just looking at what could be done and how best to go about that or not. And more recently, my work has focused on another few qualitative studies in this area with the terminology concept. And the first was a focus group study. And the objectives of this study was to investigate public perceptions on overdiagnosis and overtreatment in low-risk thyroid cancer and explore options regarding the proposed strategy to change the terminology of low-risk cancers. So we really put this to them, whether that strategy that, you know, we wrote about in the BMJ and that others have talked about in years past, whether that was something that they would support or understand, and how they kind of perceive these whole concepts. And then the second one was a citizens jury on terminology for papillary thyroid cancer and other low-risk cancers. And what a citizens jury is, it's where you get a group of citizens or people from the public in a room, and it's much like a courtroom jury. And you propose a question to them, and then over the series of a few days, experts will come in and argue the for and against argument of a certain research question, and then basically the jury will debate it and talk about why they think one way or the other, and then they come to kind of a verdict. The difference is they don't have to be unanimous in their verdict, but we did want them to kind of try and persuade each other over the course of a few days on why one person saw the other way. It's a really unique kind of newer social method that's being used in public health now. But what we wanted to do was to understand whether these informed members of the public consider a terminology change to be an appropriate means to addressing overdiagnosis and overtreatment of these small papillary thyroid cancers. And what we found in both of these two studies, almost identically, was that the public is divided on this complex issue. So there's kind of a camp or a group of people who, think that maybe this terminology should be changed. We should be calling these low-risk thyroid cancers something else because it's creating unnecessary psychological and physical harms and unnecessary healthcare costs. And then there was this other camp that kind of stuck strong and said, cancer is cancer. They were too worried about the risk of progression to invasive disease. And they really emphasized the importance of adequate care and follow-up if you call it cancer versus calling it something else. They thought, if you do call it a lesion or abnormal cells, people might fall off the bandwagon and kind of, ignore the severity of it. But if you call it cancer, which they strongly believe, no matter, how low risk it is a cancer, that, that it's just too risky to call it anything else. But overall, what we found, and it was really interesting in both of these two studies, that included a lot of members of the public, but was that the public wanted better community education and health system reforms to reduce the overtreatment of these low-risk thyroid cancers. So there was really a cry for them to be more aware of these topics, to have more discussion about it, and have it more kind of in the media and upfront when patients were getting diagnosed. And they also expressed an expectation that clinicians and researchers reach an agreement on clinical guidelines to promote better uptake of active surveillance. And I think, it is a hard concept to get people in the public to think about these things. I did my PhD in overdiagnosis and overtreatment, and it took me years to really fully kind of get my mind around the concept of it. But what they did think was that, there needs to be this better promotion of these less invasive options where possible. And I do think that that is happening in the guidelines and in practice. I'm obviously not a clinician, so I can't speak from the ground, but from what I know of my colleagues and the studies I've seen, I do think that is happening. But I do also think that sometimes the discussions kind of get left by the wayside a little bit as well, and kind of patients get pushed into certain directions without really kind of being told the whole story always. And so here are the two studies there that I just talked about out of interest. And before I kind of wrap up, I'm just going to circle back here and talk about Ian and remind you about Ian. And like I said, I'm not a clinician, so I can't speak from the ground, but I do a lot of work with patients, and that's kind of what drives me and motivates me to do my work, is the stories of these patients. And Ian here, a guy who had no idea that his life was kind of going to change in the blink of a scan, said, I got to the stage, to be honest, I got to the stage, I never told anyone this, but I got to a stage where I think I'm going to die, And so just wrapping up, there's just three things to kind of consider with all of this work. And the first thing I think is just the impact that terminology and language has more broadly on patients. What we say and how we say it, whether or not we change that word cancer, or we can whatever kind of happens in that space, just how we talk to the patients and the language more broadly does matter. And also that the short and long-term quality of life implications of low-risk thyroid cancer diagnosis and treatment has on patients. Oftentimes, when I started this work, people would say, well, thyroid cancer, it's one of the better kind of cancers, but there is really a quality of life impact of being diagnosed with a cancer of any type and the treatment that they have to go through, whether it be, really invasive or short or fast or what. And lastly, just the importance of presenting and discussing both the benefits and potential risks or downstream consequences of each treatment option to help improve shared decision making and patient outcomes. And so as you can see in these kind of three kind of summary points I have here is that what really matters is the patients, is those people like Ian. And I think we always got to keep that in the forefront of our minds when doing research or doing practice, is that it is the patients and they are impacted on what we say and what we do. And so if you can kind of consider this, group of people all having a low risk papillary thyroid cancer diagnosis, well, what we want to focus on and what I really hope to focus on in my research is, to really improve quality of life for these patients and focus attention and resources on those who really need it. Thank you.
Brooke, thank you very much for that amazing presentation, and you have done a lot of and significant impactful research. I appreciate you sharing with all of us. Um, uh, One of the things that is left to me is, you make the strong case of the terminology impact, how the terminology impacts decision making, and then when you say, okay, what that might be the next steps, can we change actually the term, can we make it something that doesn't have cancer, you have the patient saying, not so fast. I think we should keep it. It's not a problem of labeling, it's a problem of discussing it. um, how that how we make that, how do we make sense of that in the next steps in regards to terminology research, when patients are telling yes, we understand the impact, but we still wanted to label as you see it in the microscope.
Yeah, and I think that's such a great point, JP. And I think when I first started this work, that was something that I didn't, necessarily consider. I thought, you can change a term or not, and that might make a difference or not. But I kind of didn't really think about the whole idea of what patients might actually want that label for, and whether having just a wider discussion around it is important. So, after doing all those studies and stuff, people always say, well, do you think that changing the term is the good solution? And I still kind of think, I'm not sure, because I think there's two sides of it. I think when we say that word cancer, there's that initial reaction, and that is something that's really hard to take away, and hard for the person to forget, no matter how much we might explain the benefits and harms, or much we might sit down and talk about the different options. And that's, I think, what my research is really looking at, that initial kind of terminology there. But I think there's another layer behind that. It's that if we still call it cancer, we do need to then have some sort of, better shared decision making and presentations of those benefits and harms. And my studies did show that as well too, that if you do that, that makes almost just as important of a difference, and that patients rightfully want that label for many different reasons. And I'm sure in your clinics you see that as well. I think in the US, an insurance, there's an insurance effect of it as well. In Australia, it's not as much, but I think that the terminology option might be almost too tricky for those patients that you talk about, that still want it. Like I don't I don't really know where to go from there if you were to do that. But yes, I think with the whole body of research, I think we need to really think about what's driving the conversations behind that terminology, and perhaps the fear, and how clinicians talk about those other options with using the label as well.
Yeah, no, absolutely. Something that I learned from your studies is, something unique is that other groups have gone through the business of changing the label from a pathological perspective. So they got together cytologists, pathologists, clinicians, and they decide to change the label to some extent. And sometimes I think it has been very helpful. For instance, the case that you are referring the encapsulated papillary variant of follicular thyroid cancer. But this is the first time in what I know that this is actually something that you involve patients to see if actually changing the terminology is well received. And involving the patients, I think, is something very innovative on this, because I would have guessed before going into the process that they will agree that the terminology needs to be changed. And just after hearing the patients make sense of this, you kind of see that that's not always the case. How that impacted my practice? Well, for instance, I still call it cancer. Of course, I still call it cancer, but I do frame it in a way that provides a little bit of the prognostic flavor when I talk to the patient. So I don't start the conversation, blah blah blah. You do have cancer. I start saying, blah blah blah. You do have a very low risk, likely indolent, small papillary thyroid cancer with that the majority of patients have excellent prognosis. So I put a lot of flavor and labels on it, so the patients don't always get, or they don't get just the cancer thing, and trying to avoid this kind of shock, the cancer shock that you were referring to, because otherwise I think I will be nudging them to a specific aggressive treatments, and I just want them to not increase this level of anxiety so they can choose better. They can choose where, with a level of not peace of mind, but at least not driven by anxiety. So yes, so perhaps changing the terminology all the way to not having cancer might not be the answer, but maybe something in the middle, something that describes the prognosis and something that describes a little more of this cancer.
Yeah, absolutely. And I think, again, like when I started the research, I thought it was pretty black or white, like you either change it or you don't. But I think what I hope now that my work shows in these papers is like what you said, is that it, for people to, for clinicians and researchers and patients to more be aware that that word does have these reactions and does have these consequences. And yes, we still need to use it, ethically and morally and legally. Probably you cannot not say it. So we still need to use it, but as long as we're aware of what it might then be doing to the patient, and the impacts it might have, I think that's, kind of the important thing that this work is showing. Um, and like you said, trying to find kind of a middle ground, to be able to then, sit down and rationally discuss the options and the benefits and harms, um, and what's going to work for each patient rationally.
Mhm. No. Yes. Um, so let me ask you another question, because you're doing research in thyroid cancer, overdiagnosis and overtreatment, and you have focused on the kind of a transition from diagnosis and treatment. But I wonder if that is too late in the game. I have found that once you have it, once that you found to have something, a small, papillary, even indolent or not, it is quite difficult to avoid the overtreatment, because you already started a cascade of events in which the majority of the patients will still might receive treatments that they don't need. As opposed to a very a different approach of addressing the overdiagnosis, for instance. And you presented the case of Ian, and you can clearly see that Ian did not need an ultrasound to begin with. So he presented with neck shoulder, and suddenly he has an ultrasound of the neck. And we see that all the time. It's not, I don't think it's an exception, the case that you presented, but many patients have ultrasounds or imaging technologies when they don't really need it, but we use them because we have the ability to use it because it's next to us in the office. We can just put the prop in the patient's neck and it's very easy. So philosophically, are we addressing the problem of overdiagnosis of treatment at the right stage versus trying to think of maybe steps before that, before we start this cascade?
Yeah, I think that's again something that as my research went on and I became involved with more clinicians and talking to people and understanding the whole cascade of events, it definitely, that was something that was brought to my attention, is that, are we looking at the right spot? Is this, I think regardless, those things are going to happen. So I think, and the majority of the time it's going to happen, but I think like you said, you can't be overtreated if you're not overdiagnosed. So you need to kind of stop it first there. And we need to shift kind of perceptions of, what of always needing to look for something. If the wheel's not broken, do we actually need to look and fix it? But how do we wind that back when we have a society of, people who want to know about any little thing, and when we have, more people going to see doctors, maybe not in the COVID time, but always our generations and our societies, we're very health seeking. We have very high health seeking behaviors, and we want to know kind of what's wrong, and then have annual checkups when those might necessarily not be needed because there's nothing wrong, and do all these kind of investigations. So we do, I think it's a societal thing where we need to kind of wind back the whole looking, and the improvements in technology and all those kind of things. But I don't have an easy answer with how you kind of shift that that whole concept clinically. But I do think, like you said, that the intercept of picking it up before it's even overdiagnosed, because then it can't be kind of overtreated. And once you're on that cascade of events, and once you've found something, whether that, whether you think it's a cancer or not, once you know there might be something there, you want to know what it is,
Yeah.
and you want to look further, and it's always going to play in the back of your mind. We had patients that said to us before they even heard that term cancer that they expected it, because they couldn't figure out what else it could possibly be that the doctor was calling them back in to look for or discuss results for, or things like that. So yeah, absolutely.
And no, that's I agree. And I always when I talk about overdiagnosis and overtreatment, I tend to say we shouldn't be talking. If we have perfect treatments that are without any impact on quality of life, they don't cause anything, and they don't have any impact in psychological and physical domains, they shouldn't be overtreatment. It's just the right diagnosis. It's just the lack of good treatments is what makes it overtreatment. And there is a question from the audience, Dr. Urkin. He's asking about your perspective, and the ways that the different patients are wired with respect to how they will process medical information. Some patients might be more inclined to receive different methods of communication, and other patients might appreciate, for instance, more information, more terminology, and other patients might appreciate a different kind of communication technique. Do you think there is people that are wired for specific communication techniques and terminology use?
Yeah, absolutely, absolutely. And not only in this work that I presented, but I've done a lot of work with patients across many different types of cancer now. And you see it, you definitely see it. There's patients who want to just be told. They want their doctor to tell them what to do, what they have. They kind of want to know nothing and just follow the advice. There's other patients who want to know everything and be allowed to make their own decisions. And I do think that is, it's a product of the environment and how those people are individually wired and how they're going to be receptive. It's also a product of things like their health literacy, and how they kind of understand these discussions as well. So definitely, it's I don't envy you all who have to sit in the clinic and make these, have these discussions with patients and how to, read them and figure out what might be best, because it is one of those things that every patient is going to be different, and that they're shaped by their previous experiences. They're shaped by just who they are and their values and preferences. So yeah, it is a tricky thing, because I would say that some people, even in our work, that we did in those focus groups and the community juries, we have some people saying, oh, cancer, what is it? Everyone's got it anyway. It doesn't bother me now if I hear that so-and-so has it, survival rates are great. And other people saying, if someone told me tomorrow that I have cancer, I would be writing my will, I'd be taking my last trip, I would be, signing it all off, no matter what type of cancer that was, because they're just scared to death of it. They had 3 family members die of it, all these different things. So it is, it's really a product of nature and nurture, and I don't really know how best you approach that without knowing kind of how the patient is beforehand.
Yes, and in the idea of people and patients and clinicians being wired, there is this concept that has been in this field, and I have heard it in several presentations, that maybe clinicians and patients are already have a specific, they're wired to some kind of decision making. They have been described as minimalist versus maximalist. The minimalists, the ones who really don't want to have a lot of things done, they appreciate more conservative treatments and maybe more likely, for instance, to choose active surveillance. And the maximalists, on the other hand, will be the ones that want everything done. What are your thoughts about it? Are we wired for that kind of a specific way to make decisions, conservative versus more aggressive choices?
I think to some degree, I do think, it is a product of maybe our environment more, and our kind of past experiences more than how we're technically wired. But yeah, there is now, as I think you're probably referring to, there's a scale that has been developed to test that, to test whether you are more of a medical maximizer or more of a medical minimizer. But yeah, I think it's a number of things that kind of come into that concept. And I do think obviously we're all going to fall somewhere on the scale, and that I don't think there's many that are going to be at either extreme end, but in different scenarios and different situations, I do think people will sit more towards one side than the other side.
Yeah, in my experience, I don't find it that useful, and the reason is this. I have found many patients that might come with a perspective of being minimalist, and the moment that they have the cancer, they become maximalist. So
Mm,
you only know the individuals and how they behave, not how they theoretically perceive what they're gonna decide, but actually in the interaction with the patients, you can only determine what is best for them, because asking them before the encounter, oh, you're you maximalist and minimalist, that is kind of a cognitive exercise rather
mm.
than really going through a real world interaction with your patients. So I have found that a little bit problematic, that approach, but yet it's still useful, because you know that sometimes it does apply. There is a question from the audience, and this is a very relevant question, because in the past, everybody got thyroid surgery, and that was straightforward. That was easy. Everybody got thyroid surgery and then radioactive iodine. So the conversations probably lasted 10 minutes to discuss what this entails. There was not a lot of decision making. You just do it because it's a way to treat these patients, and we did not understand it at the time that we have options. Now we have plenty of options. We have total surgery, we have partial surgery, we have active surveillance, We have ablative therapies, and some centers offered actually 1 or 2 ablation therapies now. So there are 4 or 5 different options. And now these conversations have a lot of things that we need to educate, present to the patient. So how do you reconcile the need to educate, to inform, to discuss with the restrictions of time that we have for these patients? And perhaps that is one of the barriers why we tend to choose more aggressive options, because we might not have the enough time to actually address all the options. Have you seen that in your interaction with clinicians, for instance?
Yeah, definitely. And I think that's one of the things that concerns clinicians. I mean, our work really found that clinicians are more, in terms of being driven for preferences to recommend surgery, are more driven by the worry about the risk of progression. You know, most of the clinicians we've talked to would say things like, we know that there's overdiagnosis and overtreatment, but even if there's, you know, the smallest chance that something's going to progress, we're not comfortable with that. And, you know, those were things I think they were worried about, you know, the harm to their patients and you know, um, legal issues and then things like that all kind of came into play there. But I think in terms of the time, I think the whole body of work around things like decision aids and you know patient kind of pamphlets, informed pamphlets, and things like that, that JP, you probably could talk a bit more about than me and what might be useful in the thyroid space. But I think things like that do come into play and might help that overcome that time barrier a little bit. But I do, yeah, I'm to be honest, I'm not 100% sure because I'm not a clinician, so I can't really speak to say that is the time thing is really what's playing a big role there. But I can sympathize with that, and I can understand why that would be so challenging. So yeah, I think there might be things like decision aids and things like that, and for patients to
And
properly go ahead.
no, no, I do agree. But I think your findings, when you talk to surgeons, although they might not say explicitly this, I think they are coming up with the idea. I think they are saying it. You know, it's straightforward to treat these patients with thyroid cancer. It requires less time, but perhaps they are not voicing it that clearly. But I think that might be one of the reasons. Also, is that not everybody has 30, 45 minutes with these encounters. Some of my colleagues, many surgical colleagues, and many endocrinologists might only have 15, 10 minutes. And you might only have time to discuss one option, and perhaps that's again nobody's fault. I think we're doing the best in a system that is set up to constrict us in regards to time. But when I hear your research in regards to the barriers from the surgical perspective, it comes to me that they want to make it easy. They want to do it straightforward as well. But I think the time is a constraint. So I do agree that that is something that I'm not sure how we can reconcile very well. Um, Very good. And again, Brooke, this has been a fantastic presentation. I really, really enjoyed. Thank you very much for being with us. And thank you everybody for your questions. We have the next week agenda that was in the screen. And if you have any other questions for Brooke or the group, please let us know. The next actually week is going to be Dr. Tsuchitani, and it's going to be talking about the active surveillance. There was a new guidelines that came from the Japan Association of Endocrine Surgery that goes about some of the recommendations for management of active surveillance for micro PTCs, and some of those actually are extremely useful recommendations from the practice. So looking forward to that presentation as well. Again, Brooke, thank you very much for being with us.
Thank you. Thanks everyone. Yeah, and feel free to email me if you have any questions or anything.
Take care.